May I request Dr. Arthur Sitt to come to the podium, and he is a professor of ophthalmology at Mayo Clinic. Thank you, sir. Thank you for coming to India.
All right, thank you. Thank you very much. It's a pleasure to be here. So I'm going to be talking about the role of ocular biomechanics in glaucoma. These are my disclosures and really the only thing that's relevant to some of the funding. So why do we care about ocular biomechanics? So elevation of IOP causes distension of the eye, stretches the lamina curvosa, potentially damaging the axons. And so one of the questions is what tissue properties might protect against IOP-related damage? And the first thought might be a stiffer eye is what you want to protect it against high IOP. The problem is that the tissues of the eye are not uniform, and so Crawford Downs, as well as others, have shown that you can have different tissue properties in different areas. And if for example, if you had a stiff sclera but a compliant lamina, when you raise IOP, you actually concentrate deformation into the lamina curvosa, where you definitely don't want it to happen. So one of the issues then is how do we start to measure ocular biomechanical properties? One way is you can use something like this. This is a commercially available device, the Ocular Response Analyzer from Reichert, and it's an air puff tonometer, and it measures 2 air puffs. So it indents the eye and it measures the pressure as it's indenting and the corneal light reflex reaches a maximum. And then as it's rebounding, it measures a second pressure as it again reaches a maximum corneal light reflex. So the difference between those 2 pressures is called the hysteresis, the corneal hysteresis. Now, the term corneal hysteresis is probably a misnomer. Now, so one of the issues is that what does that actually mean? It's a hysteresis doesn't tell you anything specifically about the properties of the eye, and that's because tissues are usually viscoelastic. They're neither perfectly elastic or they're neither perfectly viscous. And what's the difference? So if you have something that's perfectly elastic, like a spring on a car, if you were to deform it, then the amount of stress for the amount of strain that you develop, so stress is essentially the force that you're applying, strain is the amount of deformation. It forms a straight line if you were to graph it. And if you release it, that perfectly elastic tissue goes back along exactly the same line. If you have something that's viscous, like a damper in a car, then that deforms, the rate at which it deforms determines the viscosity. So if you incorporate the two into a shock absorber and spring system that you have in a car, then as you first compress it, you might have a stress-strain curve that looks like this, and then as it releases, you have a stress-strain curve that looks like that. And the difference between those two is actually the energy that's absorbed by this system, and that is the hysteresis. So the problem with measuring corneal hysteresis is that anything that affects viscosity or elasticity of the tissue can affect corneal hysteresis. So it's very complex, and we see this in a lot of cadaver studies looking at the effect of different pressures on the eye. One thing that we know for sure is that the elastic modulus of the eye increases with IOP. As you stretch out the tissues, it actually becomes stiffer. Axial length also seems to play a role, so elastic modulus appears to be lower in patients who are myopic. And then the stiffness of the eye also increases with age. And so trying to interpret what corneal hysteresis actually means is becoming very difficult. It's almost impossible to represent the complexity of the eye biomechanics with a single number. So it's more useful to think of corneal hysteresis as the behavior of the eye in response to an impulse. Now that being said, you can still get useful information out of this, and this was the topic of a ophthalmic technology assessment a few years ago by the American Academy of Ophthalmology. And essentially what that ophthalmic technology assessment concluded is that, first of all, after reviewing all of the studies, and there's been hundreds of studies looking at corneal hysteresis and glaucoma, and so CH is lower in glaucoma patients compared to normal subjects. Lower CH is associated with an increased risk of disease progression, but a causal relationship remains to be demonstrated. And so CH measurement right now does serve as a complement for current structural and functional assessments in determining disease risk in glaucoma suspects and patients. But how do we start to determine what are the specific biomechanical tissue properties that occur in glaucoma and whether they are actually causative of glaucoma? So this gets to some work that we've been doing over the past several years using a technique called ultrasound vibroelastography. So what this involves is using ultrasound to image the eye and then using a mechanical shaker to gently generate a wave inside the eye and using the ultrasound to image that wave propagation. And so you can see here, it's actually less painful than it looks. And so you image the eye as you generate the wave, and you can see in this little video as the wave propagates across the cornea and through the sclera, and the ultrasound images it and allows us to measure the speed of wave propagation. We can also measure the ocular rigidity coefficient, called the Friedenwald ocular rigidity coefficient, using essentially a weighted pneumotonometer or weighted Schiatz tonometer. So we've looked at this in some studies. This is actually an old version of the presentation, but we've looked at this in normals and glaucomas, and we find that there's no difference in terms of wave speed when we're looking at normals versus glaucoma, treated glaucoma patients. But we do see that in treated glaucoma patients, the ocular rigidity is lower than in normal subjects. And so what does this tell us? First of all, the lack of difference between wave speed tells us that that viscosity may be more important, and we're only looking at cornea, and so sclera is probably more important than cornea. It's also complicated by the fact that all of the subjects in this initial study were treated with prostaglandins, which can affect the biomechanics because of their effect on matrix metalloproteinases. So, and so to try to get around this issue, we started looking at normal tension glaucoma patients because we could match them for age and IOP with controls but still have these patients untreated. And so this was some fairly recent results that we've published. And what you can see here is that in normal tension glaucoma patients, first of all, the wave speed is higher. And what that means when the wave speed is higher is that the elasticity is higher. So glaucoma patients have stiffer optic nerve heads and stiffer optic nerves. And then the viscosity in the optic nerve head as well also tends to be higher. So higher viscosity means that it deforms slower in response to a force. So why would that potentially contribute to glaucoma or predispose to glaucoma? And the reason may be related to IOP fluctuations. So IOP fluctuates when the volume of the eye changes. And this goes to the idea of compliance. If you think of the eye as a balloon stretching and contracting, the only way that pressure changes is that volume changes. And if that's the case, then that means if you have an eye with lower compliance, so a stiffer eye, you're going to have greater IOP change for a given volume change, which means greater IOP variations. And we see this in some patients. And so we looked at a very select type of patient, and that's patients who have had scleral buckle surgery. And you might think, why is this related to glaucoma? So scleral buckles have the effect of changing the ocular biomechanics of the eye. And so we looked at patients who had unilateral scleral buckle surgery for retinal detachments, and we measured ocular biomechanics and IOP changes in the sitting and supine position. And what we found is that first of all, the seated IOP in these patients was no different between the normal eye and the scleral buckle eye. But when you measure the pressure in the supine position, the pressure increase in the eye that had the buckle was less than the pressure increase that did not have the buckle. So the pressure variation was smaller in an eye that has a scleral buckle. Similarly, we find that ocular rigidity is lower in an eye that has a scleral buckle than an eye that didn't have a scleral buckle. So the eye actually, the scleral buckle actually makes an eye more compliant. So this was actually very supportive of some work that we did earlier looking at the risk of glaucoma after vitreoretinal surgery. And this kind of tied it all together. So we looked at the risk of glaucoma in patients who had either vitrectomy, scleral buckle, or vitrectomy and scleral buckle. And this was a population-based study. And what we found is that if you had vitreoretinal surgery, you had a higher risk of developing glaucoma. So that's not going to be a surprise to most of us who have to deal with patients who have had vitreoretinal surgery. What really surprised us, though, is that that was completely driven by vitrectomy. So if you looked at patients who had only scleral buckle, 0 patients developed glaucoma, and so that was actually less than the population norm. So based on this work, what we think is the role of ocular biomechanics. First of all, corneal hysteresis is a complement for current structural and functional assessments in determining risk of glaucoma in suspects and patients. The corneal wave speed is probably not going to be much use because we have to look beyond the cornea. And looking at our work with normal tension glaucoma patients, we do see that there is increased stiffness in patients who have untreated normal tension glaucoma, and we think that's because the increased stiffness increases IOP fluctuations, which has definitely been associated with glaucoma and the risk of glaucoma progression. So there's still further research that's needed, though, to determine if we can alter ocular biomechanics as a potential treatment for glaucoma, and this is clearly a potentially new target beyond simple IOP reduction. So thank you very much, and hope to see you all at WGC in a few months.
Thank you, sir. Professor Sid, sir. Is it the corneal hysteresis or the Young's modulus elasticity that we calculate with Young's modulus, which is clinically more relevant? Of course, calculating, Young's modulus is more difficult.
Yeah.
But clinically relevance is of which is more clinically relevant?
Yeah. So in terms of which is more clinically relevant, we don't know. So corneal hysteresis is not a tissue property. It includes both elasticity, so Young's modulus, as well as viscosity. Which of those two, elasticity or viscosity, is more important? Probably both of them.
No, sir. So that's what I wanted to know actually, because Young's modulus will measure the elasticity.
Yes.
Corneal hysteresis measures viscoelasticity. So which of the two is more important in the causation of glaucoma?
Yeah, no, so we don't know. So some of the data that I showed you from our normal tension glaucoma study, both viscosity and elasticity change are different in normal tension glaucoma patients. So both of them matter. Corneal hysteresis is a measure of neither viscosity or elasticity. It probably incorporates both, and as well as a lot of other factors beyond those two parameters.
And one thing you said is lower hysteresis is associated with more progression.
Correct.
And prostaglandin analogs, you said, by metallic MMPs, they will increase the hysteresis.
Correct.
So by that thinking, will ROCK inhibitors also have effect? Because they also cause actin, myosin dissociation in the trabecular meshwork. Maybe they have something to do with the scleral rigidity and the corneal hysteresis also?
Yeah, so one of the complicating things about corneal hysteresis is that it's very susceptible to changes in IOP. And so just lowering IOP is going to increase your corneal hysteresis. And the effect on top of that of whether you have remodeling in the sclera from prostaglandins or whether you have changes from ROCK inhibitors, we don't know what the contribution of the change in corneal hysteresis is from IOP versus the direct effect on the tissue properties. But there probably is an effect.
So the ocular response, and sorry, yeah, go ahead.
You said corneal hysteresis is certainly going to create a kind of risk factor for glaucoma suspect patients. So, do you see that it will become one of the risk factors in coming future to start the therapies or something like that?
Yeah, so I do use it routinely in my patients. The problem is that, you know, kind of going back to what Alex said, it's another device in the clinic. It's very specific for measuring corneal hysteresis as well as IOP. You know, most clinicians aren't going to have it just for that purpose. But I do use it, and I kind of use it kind of like central corneal thickness. It doesn't tell you definitely if the patient has glaucoma or they don't have glaucoma, but it's another risk factor.
So the ocular response analyzer is the only machine which is existing in the market for many years, and which claims that it measures the ocular the hysteresis. Now, what I have two questions: that does it measure ocular hysteresis accurately, number one, or should we rely on that finding, number one? Number two, do you yourself incorporate that figure or that finding in the glaucoma management?
Yeah, so as I said, I do incorporate it in my practice because I have the device already. I use it very much like I would use central corneal thickness, or even IOP. I mean, those are risk factors. They don't tell you whether a patient has glaucoma or not, but I use that as another piece of the puzzle as to whether the patient has glaucoma or not. In terms of your first question, does it really measure corneal hysteresis? Well, yes, it does, because that's the device that defines corneal hysteresis. And you know, the accuracy really is depending on the quality of the scan. So it does give a quality scan a wave score. So as long as the wave score is accurate, then it takes multiple measurements and takes a mean, or you're going to get an accurate corneal hysteresis. But what that means, I think that is the real question. You know, what does that mean physically for the eye? And then that's where it becomes very complex. It doesn't measure a specific tissue property. It's just the response of the eye to a pressure impulse.
No.
Yeah. Yeah.
As clinically evident that micro-ophthalmic eyes are having usually higher pressure. So is it compacted scleral collagen fiber in those cases which is responsible for this high scleral hysteresis and leading to the IOP?
Yeah, so I think corneal hysteresis really is a misnomer. There's absolutely no way you can compress the eye and only affect the cornea. So I think it does reflect the entire eye and primarily the sclera. So yeah, I think it's what they called it, and because that's the only device that measures it, that's what they've stuck with.
Sclera can compress the choroidal vasculature and it can lead to poor disc perfusion. This could be one outcome of your study that might, what we are naming it as a normal tension glaucoma, could be because of this poor ocular perfusion, disc perfusion, because of this thicker sclera and high collagen content.
Yep.
Can we think of this way?
Yeah, so I mean, I've never measured patients, or I've never performed any study systematically measuring patients who have thick scleras. I think it's a very interesting area to look at. You know, thick scleras don't necessarily mean that you have different scleral properties, but you just have a lot more of it, and how that affects the overall biomechanics of the eye. I don't know for sure.
Okay,